Okay, great. My name is Kåre Nielsen. I'm an osteopath and a physio, and I'm also organizing classes with Barral Institute in Denmark, as well as being a lecturer for the Barral Institute. I have here with me today Gail Wetzler. I've done a bunch of classes with you, Gail, and in my opinion, you're very, very thorough in the way that you teach, very solid understanding of the material, and the theory is always backed up with references. Your didactics in the labs that we do are, and the explanations are very clear and detailed. So I've been very happy to do classes with you.
Well,
Uh,
thank you.
Particularly one class that I've seen with you in air in concussion class. I really liked some of the links that you did with the container and the contents, so the brain versus the cranium and the body versus the head. So
Mhm.
that brought up a good perspective on how to work on concussion. So this is what I really want to talk to you about today. And I'd like to
Okay.
pose a few questions to you, and I'd like to a little bit for you to introduce yourself. Who are you really, and what was your journey
Really?
coming into manual therapy?
Yes. Well, thank you, Cor. It's been a pleasure to work with you all these years and to be invited to come and share some of our experiences with the concussion. I began when people ask what was my journey like, even to become a physical therapist, which I am. And then I journeyed into becoming a doctor of physical therapy because there's so many questions that came my way as a teacher, and I wanted to back up some of the work that we did. Therefore, I wanted to go back and get a little bit more information for myself to help all the other instructors at the Barral Institute and move forward with this work, not only for the validity, but the reality of changes that we can make in the body. So when you asked, you gave me a little question beforehand, and what was my journey? I have to begin and share with you and your audience. When I was 5 years old, I'm athletic and I wanted to play, and I was 5 years old, and we were in my backyard and we were playing duck, duck, goose, the duck, duck, and the goose and all that. And one person said, I can't play anymore. And I go, what? And he goes, I have a headache. And I go, a headache? What's that? He goes, I don't know. I just can't play anymore. And he was holding his head. So we all took a break and we got some water. And then I went over to him and I said, where is it that you hurt? And he pointed to here. And all I can say, not knowing what I was doing, I put my hand on his forehead and hand in the back of the head. Maybe 3 minutes goes by and he goes, what are you doing? And I go, I don't know. He goes, my headache's gone. I go,
Oh,
good,
wow.
let's play. That's all I wanted to do was play. I didn't have any idea. And then later, maybe when I was 10 or 11, all I have are brothers. And I finally had a big party at my mom's house, and another girl was there, and she was 12-ish, and she had a stomach ache. And that was probably her period, starting, and a stomach ache. And she goes, oh, I can't play anymore. And she was the only girl, and I really wanted to play. And she laid down on the bed, and I went behind her, and I put a hand on her belly and a hand on her back. And she goes, after a few minutes, what are you doing? And I said, I don't know. And she goes, I feel better. And I go, good, let's play. And so, not knowing that and what we know today and what we can train our hands to do, that's what really got me interested in, did I want to do veterinary medicine? Do I want to do dentistry? Did I want to be a doctor or a lawyer? Things like that. It was coming back to those roots of what my hands shared with me at that time as kind of guiding the yeses and nos of what I wanted to do in life.
But
So
isn't
that's
that
what
really
started
what you
it.
were doing already? Still, you're still saying after you showed something in the lab and in your teaching, let's play,
Let's
right? You're
play.
still
That's right.
inviting us to feel and to experience, to play with
Yeah,
manual therapy, right?
to play with that. Yeah. So
Yeah.
that's what carried forward. And I'm just happy to that we have the skills of what's manual therapy, even though our background might be DO or physical therapy, chiropractic, and massage. It's just that I'm really glad that we still have it. And, that is being threatened in today's world of education. They're taking away manual therapy and just doing exercise. So I'm happy to um, share with your group and maybe come to Copenhagen to go over some of the skills that we've learned in the concussion research project and to what did we learn from that. So I want to share that today. It's exciting.
Good, good.
Yeah.
So originally, when did you first connect with the Barral Institute and Jean-Pierre and
Well, it's really when did I went kind of meet Jean Pierre because the
yeah,
Barral Institute was long after I was with Jean Pierre.
right.
So it was in the late 80s, early 90s that he and I spoke at Beyond the Dura. So that's a conference that Don Upledger put on. And I was a speaker on multiple personalities and what I had done for that multiple personality patient. And Jean Pierre was there speaking on visceral manipulation. And I was very excited to hear what he had to say because at that time I was a teacher for the Institute of Physical Art here in the United States. And that's a big postgraduate physical therapy program. And we'd go through the organs to get to the psoas muscle to make a change on the spine or the disc and et cetera. And I went, oh my gosh, this stuff we're going through seems to be really important. And so I hope I can get casual, but at the pool that evening after we both spoke, it was like we got together and I said, I'm really interested in what you do. And this is what I have done in the past. And I work a lot with orthopedic sports medicine. And I'm just finding what you're doing interesting. And he just said, well, I'm coming back next year if you want to take the course. So from that point on, we have known each other for 38 years now,
Wow.
and been friends and colleagues ever since then. And so we met at a conference, but it's just been the invitation has been really open from him to learn more and more.
And it still is, isn't it?
And it still is.
Yeah.
Yes, it still is.
So who's been your biggest mentors, most important mentors in your life as a therapist?
As a therapist.
Yeah.
I have to say that I'm older than all of you on this call. So that I go back to my first mentor who I knew and worked with was Dr. Janet Travell, and she was President Kennedy's doctor. And after she had done that, she went on to do more studies into the integration of the body. And she'd look at the body as a whole and how the leg length discrepancies were. And it really interested me. And what she did with at that time was the spray and stretch.
Right.
And now it's come into needling, and now it's come into even ultrasonography and regenerative medicine. But at that point, we were looking at trigger points, and she has her big charts. So I learned extremely amount from her, even though she was a physician and I was a PT, how she looked at the body and how she made changes. And then I met Dr. John Upledger. I went to Michigan State University, did some postgraduate work there, met John Upledger, and just got together with him and what he was doing. And he invited me down to Florida. And so I learned a lot from him in regards to discovery by learning, keeping your mind open, um, keep looking, even though when you think you got it, keep looking, for the answers and in
Yeah.
some way with your hands and observations. And Greg Johnson, who I mentioned, the Institute of Physical Art, he was influential from us as physical therapists looking at a shoulder and getting prescriptions that were work on the shoulder only. And he was a little rebel like I was. He said, well, what about the whole body relationship to the shoulder? So he brought in Feldenkrais work. He brought in Aston patterning into our programs. And then he asked me to teach for him. So then I was still teaching for him when I met Dr. Jean-Pierre, when I met
Yeah.
Jean-Pierre Barral. And then when Jean-Pierre asked me to become a teacher of the work, it was in his class, actually in New York. And he said, who can come up here and age this lesion by putting your hand on that or over it? And no one else was volunteering. So I kind of went up and I said, I'll learn by this experience. And when he saw me go up and be a little brave about it, kind of get it close to being right, but and that's when he asked me, would you like to become a teacher? Because
Right.
I was being able to be intuitive and yet therapy oriented as well. And then I think those are the main people who really influenced me, honestly, in my growth, and have stayed with Jean-Pierre and all of you since then, because we are a family and we're so open to learning.
Well, so knowing a little bit about their background, I can gather your pathway and how they could change your clinical approach. Can you then talk a little bit about how that changed along the way?
I would say mostly because I was athletic myself as a youngster. So I did a lot of sports. And to this day, I now work as a women's health task force for the United States Olympic and Paralympic Committee. So I've always been a sports person, but they've always been specific to work on this knee. And those influences really shared with how changed me clinically is to look at the whole person and bring that into the picture, which I shared back with them.
Mm.
And so now I'm being called in elite athlete care as to we've done this, check, 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 the typical things.
Yeah.
What is it that you see different, Gail? And
Hmm.
in my APTA, I teach for the American Physical Therapy Association, and they asked me to teach for women's health. And so they are kind of working in the pelvis underneath the panty line.
Yeah.
And I just said, gosh, there's so much more to what produces pelvic dysfunction. And
Right.
so I've helped them look at the wholeness of the body as well. So for clinically, that's been the biggest change for me.
That sounds like a great route, right? So
Yeah.
I, I similarly also work my way into looking at the whole of the person, and that is a pathway that I'm following as well. Can you share a clinical experience that changed how you approach concussion recovery?
For concussion recovery,
Yeah.
one clinical, well, I maybe I could share with you guys a little bit about the concussion recovery program because I think I cover that in a
Uh-huh.
little thing I put together for you. So if it's all right with you, I'm going to go to a little PowerPoint for all of
Oh,
you.
nice. You got a
Yes.
presentation.
Thank
Yeah.
you so much.
How is that?
It works.
Works good. All right. I'm just going to bring me down now. All right. So welcome, everybody. I just want to share with you a little research that we did since CORE wanted to know a little bit more about the concussion recovery and what really clinically helped us move into this direction to even develop a course for everybody. So let me just kind of share some of the beginning stages there. What inspired this research project that we here in the United States were devastated by the loss of lives due to the severity of symptoms. And that chronic traumatic encephalopathy was being noted and that people were taking their lives. And it was just for those of us who care and were into the medical health field, it was just devastating for us. And there were a few of us that got together in regards to how can we help the person who suffered from one of or several of these concussions that has taken their lives. So I took this project on and I wanted to study the literature. I just went on the background and studied what other people were doing, what other doctors, what were they finding, what was the typical program other than smelling salts, get them off, maybe they'll get back into the field and then they can play. And they were not evaluating them there efficiently on the field either. As an athletic training, I was seeing this. And so what else could be done differently? And so could we, as the type of work that we do, could advanced manual therapy techniques assist the natural healing process after tissues have been damaged? So that's what I went in with as to what were they doing? What can we do differently? And can we put this into maybe a research project for us? And actually, we finally did that. So the pilot program for former professional football players, we did 2 summers of projects with them, and we had 12 uh, players that were already retired. And we designed for individuals diagnosed with post-concussion syndrome. So we had, kind of vetted them into that to make sure that they had this syndrome as a diagnosis and that they were post-professional football players who'd been through quite a bit. So the medical complexity was a new treatment approach for special population. Our purpose was to determine if specific manual therapy techniques would provide an intervention with positive changes to enhance recovery or at least diminish long-term sequelae for post-professional athletes with a history of concussions. And this is where I got validated myself. It was a thought, it was an idea, it was a dream, right? I imaged this, just hoping to come true with that. But when I went to neurology and Dr. Christopher Giza, he's on the board for concussion recovery internationally. And he's one of the neurologists on board. And I based this back based on the practice parameters of sports concussions. And at the end of his article, he said, what interventions enhance recovery, reduce the risk of recurrent concussion, or diminish long-term sequelae? And I went, oh my
Yeah.
gosh, that's it. That's our
Mm.
invitation. I was so
Yeah.
excited to have a neurologist, be asking that question. So it opened a huge door. And what we did in these two studies and putting them all together, that the objective findings was that any mild traumatic brain injury, there's a primary and secondary injury accompanied by glial scar formation. And so what do we feel when we go in, not beyond the dura, right? We're into the skull, we're into the sutures, we're into the membrane system. What happens when we go and we are attracted with our hands into the potential of a densification, which is glial scar formation when that happens? And the primary is direct damage to the brain parenchyma, so the cells themselves. And the secondary injury consists of mechanism as anything that is neuroinflammatory, cytotoxicity, oxidative injury, and inflammation. And there's probably 8 gold standard tests that I did. I just want to give you a flavor for what that consists of. And we did cervical range of motion, we did headache, we did cervical genic pain, a body pain scale, we did sleep, we did nutrition, and on here also is just quality of life and the changes that we made. And what the test consisted of was a pre-test. They came in on, say, a Sunday. We did the pre-testing. We treated him in an intensive until Friday. Friday, we rechecked him on our findings for the evaluation, and then they did the standard 8 tests again, which were cognitive, and they're like the one on the right here that I'm pointing to with the pointer. That is a Dynavision 2 test, and that is for neurocognition, reactionary times, timing statistics, and the average responses one does, because it has to be brain associated with reaction times. And every one of those tests, I just showed you a few, came out positive, not only post-test, but also 3 months later for the sustainability of what we did as in the manual therapy program. So we were pleasantly surprised. I mean, we were just hoping, but we were pleasantly surprised because we looked at the whole person, not just the brain as a brain injury and isolated it there. We looked at how it affected the microbiome, the gut-brain connection, the vascularity, other peripheral complications. Like everyone, this is interesting statistic. Every football player that came in that had the concussion that we were evaluating said that, I had an old knee injury, I had an old shoulder injury, I had an old hip injury, and ankle injury. And every single one of those injuries got worse after I had the concussion.
Mm.
So you see the high relationships in a central to peripheral nervous system relationship there. So every single one of them. So that was an interesting statistic for us. And I want to share with you the outcomes, because if the pressure system is not balanced, the brain will always register a problem. And that's a quote by Jean-Pierre. All of the participants had what's called the triad of compression. That's much more from the Upledger program in regards to craniosacral therapy. That's John Upledger's kind of dimension behind when someone gets depressed. Are they depressed physically? Are they depressed emotionally? They have these 3 things involved with a restriction: the lumbosacral junction at the dura, the occiput atlet at the dura, and the sphenoid base restrictions. When a person comes in with all 3 of those, they go, the body kind of gives them no choice, but things are shutting down and they start to go into some kind of depression. On the cranial findings, we found the meningeal primary restrictions. That's the pons cord tract, finally up where the tentorium meets that brain stem, and that gives so much information from the body up to the brain and the brain back down. The primary region was the craniofacial junction. I'm going to pause here a moment for those of you who would love to know a little bit more about this work. The neuromeningeal class level 1 is one of those that is so helpful and beneficial to come into this class. And I think Core is going to talk about that as well in regards to this class. But that was a huge finding for us, and why they would have hormonal possible changes as well because of the pituitary and hypothalamus behind this area in the brain. And vision problems, tremendous vision problems. The fascial restrictions were found in the cervical thoracic cavity in all cases, not just the cranial cavity, all cases, cervical and thoracic. What was found in the spinal mechanism of dysfunction was 11 out of 11 of them, T7 through T9, every one of them had a mechanical dysfunction. The organs most frequently found were with the loss of viscoelasticity and motility were the heart, a high pressure system protective mechanism, the lungs, kidneys, and liver, highly volatile vascular organs there. The pharyngeal basilar restrictions. I'm saying this because most people that may come into US therapists are complaining of their neck, the cervicogenic part of this, but please remember the circumference of the neck as a whole. And we found tremendous amount of restrictions in the larynx and the pharynx and the hyoid function and ability to swallow. And vagal responses you'll see below here. The cranial nerves most often found were the optic nerve, trigeminal nerve, which innervates the dura, the vagal nerve, and the vestibular cochlear. So those of you who've had concussion patients, you kind of relate to the signs and symptoms based on these cranial nerves that we found most often. And how this information has influenced the treatment strategy in all future concussion patients, which is your question, Cor.
Yeah.
Basically. For me, it established a premise in clinical reasoning for a whole body approach. Really gave us some significant statistics around that. It helped me identify how specific manual therapy techniques can enhance our treatment outcomes for concussive injuries and their related symptoms. They helped identify for us the palpation and therefore directed us into a course that what palpation and what identification of fascial restrictions within the articular system, visceral, neuromeningeal, and vascular systems of the body as they relate to how do we help the body get back into balance, right? And those what were the findings that helped us really project and open up into a program. So an example of this would be the brain requires a constant pressure in order to function. So we teach about that in this course. And the three components of intracranial pressure are the cerebral tissue volume, the intravascular volume, and the cerebral spinal fluid volume. So the treatment considerations to help change intracranial pressures, we vary the body positions based on even how their injury was. You know, if you were in that squatted position and you got hit from the side in that squatted position, then your knees were in a bent position, and that's where we need to be thinking about functionally treating you because that's where that injury occurred. Maybe you were speared and into the abdominal or hit from the side, and you treat the intra-abdominal and thoracic pressures. Maybe that's where we, as finding our general listening, going to, no matter if it was a concussive, we find the general listening to be more primary in another area of the body. So that helps with the pressures of the intracranial system. We work with the brain vasculature during inhalation and exhalation, inhalation helping that volume. And so then we treat the jugular and portal vein system for proper function as well. And so that's all helpful for the intracranial pressure that I do not see in other classes and other literature in any of the research that I did. And it helps us understand the connections between our organs, our emotions, pain, and trauma of the concussed patient. And I will pause here a moment just to share with you, when we were doing those intensives with our guys, there was not any of us that did not have a Kleenex in our hand. Their stories were immensely emotional. Breakup of relationships, being on the NFL and, oh, you can't play anymore. Bye, you're out. You're off the train. We no longer take care of you. It was really, really tough to hear their life stories. And so the emotions were real, very real. And then what you might look forward to in this course, I just want to give you a brief outline for it is a 3-day educational program. The title is In Clinical Interventions for Concussion Recovery. You will all learn about the concussion science. So what was early management to current management and the much bigger programs that they're doing these days all over, including on the field and in the practice as well as the games. Concussive screening evaluation. I have developed probably 4 different screening programs that we don't do in the other parts of the Barral curriculum based on concussion, based on mild traumatic brain injuries that through the discoveries in this research. We certainly share with you layered palpation and listening to the cranium in much greater detail. We talk about the brain characteristics after a concussion. What are the symptomologies that you might be listening to with your ears to say, to even ask the question of your patients, you know, have you ever had a hit on your head? Some of the things you're saying to me remind me that you might have had a hit on the head. Go back years, go back when you were a kid. And so that changed me in my questions as well. We went into loss of consciousness based on medical research. And now there is one section in our program that you can identify by brain functional listening if a person has had a loss of consciousness. When I teach a class, I say, how many of you have had a loss of consciousness? And ask them to raise their hand. And many people don't remember that they did. Yeah, I remember blacking out, but I don't know if I lost consciousness. So based on this class that you'll take, you'll be able to share with them. And we just have to follow the pathway of the injury through the brain. It's really fascinating. Visual functions, we go into vestibular testing, vision testing, sensory considerations for that. The confluence of tensions, that's where we will be talking to you about brain pressure changes post-concussion and what techniques we use for that. What were the most common dysfunctional organs, which I shared with you. We will go in and make sure that you are aware of those and do some treatment. The common cranial nerves, we identify and give you some treatment approaches. And then we want to be sure that we keep you excited for always learning by discovery. What is your intention with your hands? And to always stay curious, everybody, stay curious. And that's what I wanted to share with you. In answering that question, I hope that covered it, Cor.
Yeah, and then some.
Yeah, good.
That's very good. So really, what inspired you then to create this class? I mean,
Yeah,
obviously you've been working with concussion patients, and
yeah.
what then made you make a class like this?
I just thought the information that came from the program, the research program, needed to be shared. I really wanted to be able to share that. And so luckily, you and I work for a company that was willing and open to be able to sponsor that and put it together for us.
Yeah,
And so thus, how many years now have we done it? 4 or 5? Maybe 5 or 6 years. It was before COVID we started. Maybe in 2018, we had our first course.
right.
So we've been doing it at least once a year ever since. It's a specialty course. But those that have had it, you know, many of our students who have had it have had some kind of head injury and they benefited themselves even from taking the course. In Scotland, if you remember, Core,
Yep.
we had Barbara from Australia up, and she's had a number of concussions, and she was one of the demos that I had there. And she wrote me back after that course. She said, "My life has changed with you
Oh,
looking
wow.
at the total of the body
Uh-huh.
and other people trying to help." She was just absolutely ecstatic for the type of work that we did with her. So it's great.
Good. Yeah, yeah, yeah. And for me, also a great experience to take that class, and I really look forward to having you teach it here. So, yeah.
Great. Good.
Thank you for sharing all this information.
Thank you.
Yes, you're
That was
welcome.
amazing. I also included in the chat for anyone that wants to learn more or even sign up today. You can just follow the link in the chat, and we would love to have you in October.
Great.
All right. Thank you, Gail. I think you got to
Yeah.
run. You got to go work, right? So
Thank
thank you
you
so much
so
for
much,
taking the
Gail.
time for the
Yeah.
Yeah,
interview.
you're welcome.
I'm going to go ahead and stop the recording. Have a lovely weekend. Thank you so
Thank
much for
you.
making the time.
Bye.
Bye.
Bye.